Hi, welcome to Healthy Living. My name is Amy Bouton. I'm Director of Communication and Marketing for St. Tammany Health System. So May and June and the summer, all those things are happening right now. And during the months of May and June, we like to talk about women's health and men's health. And today we're going to zone in on heart health in particular. So I brought two special guests with me today, and I'm happy to welcome Dr. Merrill Laurent. Dr. Laurent is an internal medicine pediatrics physician with our St. Tammany Physicians Network in Mandeville. So thank you, Dr. Laurent, for being here.
Thank you for having me.
It's so nice to see you, and you join us every once in a while, and you share lots of information. As a primary care physician who does internal medicine, you have a lot of knowledge about relationships with your patient and how important that is to learning about health issues before they become a big problem, and that's important, and we want to touch on that. But first, before we get into anything about our topic, I want you to tell people about you.
Okay. I've been in practice for close to 30 years doing internal medicine and pediatrics. Trained at LSU in New Orleans and moved over here in the late 90s to start practice. Was in private practice for a number of years before joining the St. Tammany Physicians Network. I also serve now as the Ambulatory Quality Director for the Employed Physicians Network.
Okay.
So I get to look at statistics and see how we're doing compared to other groups in this area and in the nation.
And that helps you, I think that helps, and correct me if I'm wrong, helps you inform what to do for our particular population.
Exactly. So I get the data on what the trends and the guidelines and the recommendations are and kind of break it down to actionable items for our providers to be able to take care of our patients.
Okay. So we are here to talk particularly about heart health.
Mm-hmm.
So when a patient comes to their internal medicine physician, how is their heart health assessed over that time in that relationship?
So we were all trained. There's an old saying, if you listen long enough, the patient will tell you their diagnosis.
Ah.
Yeah. And I remember back in training, we were told 90% of getting the information, getting to that diagnosis is based on the history and a good physical exam. So really asking them, we want to know what they're doing in their life that may be leading to increasing their risk, smoking, obesity, sedentary lifestyle, high stress, also family history. If everybody in the family had a heart attack before they were 50, that's something we need to know about.
Right.
So we get a good history and then a good baseline physical exam, listening to the heart and lungs, checking their pulses. Just the basic stuff will get you close to 90% there. And then based on what they're telling you, then you take the next appropriate steps. If somebody tells me I'm having chest pain, well, of course, elephant on the chest, that's an easy one.
Right.
But if somebody just is getting a little tired and when they're doing their yard work, they can't do it as well as they used to, we have to figure out, is that just a natural part of aging, or is there something else going on? And that's where that long-term relationship with the patient does help. Yeah,
because you know them.
Right.
You might see them only once or twice a year, but you know them and you know their history.
Yes.
So you mentioned some things that might, raise a red flag for you as their primary care to elevate them to the next steps in the process if you think something is heart related. What are some other things besides tiredness that they can't explain, or shortness of breath, or?
So we look for, as primary care physicians, the primary cause and the primary disease: high blood pressure, high cholesterol, diabetes, obesity, those sorts of things, and try and work on those risk factors to control those disease processes and thereby lower their risk of heart attack and stroke.
Yeah, and so that's where some medical intervention can come in. I know you probably recommend lifestyle changes and things like that.
That is first and foremost for everyone. We all need to do better, myself included. I'll say lifestyle changes: get up off the sofa, go outside and walk the dog, do the things that we all need to do more. Stopping smoking, including vaping, cutting down on the fats and cholesterol in our diet, watching our carbohydrates and our sugars, all those typical things that we talk a lot about,
right,
and are so hard to do in South Louisiana.
They are hard to do. And so there are things that you can do medically for people to aid them
Absolutely.
in preventing, heart attack, stroke, and things like that.
Yes.
So can you talk a little bit about those options?
So one of the biggest things that I can do besides putting someone on a blood pressure medicine to get their blood pressure under control is control their cholesterol. That's one of the biggest risk factors for heart disease. So we use various medications and some supplements. The over-the-counter niacin, omega-3 supplements do help, and if somebody has a mild elevation in their cholesterol, then we go with that. If it's more severe, we step it up. We talk about the LDL, which is the bad cholesterol. There's enzymes in the liver that can capture the bad cholesterol to process it and get rid of it. And there's also the liver itself makes cholesterol.
Okay.
So there's a two-pronged approach. And so statin drugs, that's one of the most famous, biggest ones that we have to use, work through decreasing the amount of cholesterol that the liver makes. So it can lower the amount of bad cholesterol your liver makes and sometimes increase the HDL, or the good cholesterol, a little bit. So statins are a huge part of our arsenal for treating and preventing further issues with heart disease.
And that good cholesterol, bad cholesterol, it can confuse people.
Right.
So it's good that you're explaining it now and how it's produced and why it's important to know your levels of cholesterol.
So 200 is kind of the cutoff. We say, oh, your cholesterol is under 200, your total. And that's a good screening. But for folks who maybe have some risk factors, or definitely if a man walks in and he's over 45, I'm going to start looking for a full panel to get the breakdown of the types of cholesterol. Women over 55, because estrogen tends to help protect women a little bit from heart disease and sort of delay that progress. So we're going to screen. We're going to get the full cholesterol panel, and if your LDL, your bad cholesterol, definitely if it's high, we're going to want to treat it. If it's over 160, we call that high for just anybody. And if it's over 130 for folks maybe with one or two risk factors, then we want to get more aggressive with that. And then if you have active heart disease or have had a stroke in the past, we really want to get aggressive with that.
Right.
There's a good tool that we use that is a combined effort from the American Heart Association and the American College of Cardiology in our electronic medical record that if I put in this little phrase, it goes in the background and gets all the demographic data on the patient.
Okay.
Age, sex, race, history of their blood pressure readings, their cholesterol readings, any history of diabetes, those things, and comes up with a 10-year risk factor of having an event.
Interesting.
So if your risk factor, if that pops up greater than 20% over the next 10 years, I'm going to really push to want to put you on something.
Yeah.
If it's between 5 and 20%, sometimes, depending what the numbers are, we can go with lifestyle changes and maybe some other medication. And but if it's high, we're going to want to put you on something like a statin.
And so let's talk about statins and why they're commonly prescribed for patients that are at risk for cardiovascular disease. What kind of evidence-based kind of information do you have on that?
So the first statin, Mevacor, came out in 1987. I had to look that up. That was, I was just starting my training back then, and I don't think they sell it anymore. It was good. I mean, it was groundbreaking, but it wasn't potent enough.
Right.
Then we have much better options since then. So back to the late 80s, we've had evidence that the statins reduce the cholesterol levels, but also we do show that being on a statin, getting those cholesterol levels down to controlled numbers, can lower your risk of a first heart attack 25 to 30%.
Wow.
First stroke reduction 25 to 30%. Risk of having to get a stent in your artery of your, coronary artery of your heart can reduce that 40%. So we really have good evidence with multiple long-term trials. There was one they called ISIS back before that was a bad term. There have been multiple trials called the HOPE trials. I know they've done the HOPE 4, so multi-year trials. And really, I do attribute some of the early information from the Bogalusa heart study, which maybe some
Right
of,
here.
some of our viewers may be participants in. Back in 1973, Dr. Gerald Berenson, who was a cardiologist from Bogalusa, started this longitudinal study, enrolled I think 16,000 people in it, mainly the younger population, thinking to study them, and then they added folks later. Really found some significant problems with cholesterol. They were doing autopsies on people who died from various causes, mostly accidents, and found that as young as 3 to 5 years old, kids were starting to have some fat deposits in their aortas, and preteens were already starting to have some plaque development.
That's very interesting.
Yeah.
And surprising, really.
Right. So that really, was in the 70s, so that really pushed the development of the statins through the 70s and into the 80s.
Okay.
Yeah. And so we can look at that now and say, as you develop the plaque, if we just want to think about it like the clog in your sink, the goo around the circumference of the pipe, right? That's sort of the pipe of the artery. The plaque develops around there, and maybe you start having a little bit of decreased blood flow as it gets smaller. Maybe you're just not quite as energetic as you used to be.
Sure.
But then when a piece of that breaks off and goes downstream, then it causes a complete blockage, and that's when you have the, depending on where it is, heart attack or stroke or other issues. So the statin drugs help, in one sense, keep that plaque that's around the circumference stable, so it doesn't want to break loose. And over time, after about a year or two being on a statin and having good cholesterol numbers, those plaques can, to a certain extent, shrink.
Oh, wow.
So there's a small amount, it's about 3 to 6% shrinkage, but the stabilization of the plaque is, I think, the biggest issue. Our bodies naturally try to stabilize it by putting calcium deposits in the plaque to make it hard plaque, and those are the ones that can break loose. That's the more dangerous ones over time that can break loose and cause the heart attack or the stroke.
So that's interesting that you explained how it works, because I've heard about statins, and I never understood exactly what they do within your body.
Yeah.
So I hope that our viewers have a better understanding of that now. And obviously, if someone is going to be prescribed a statin, you consider all the risk factors of taking that drug and prescribe it for people who have the least side effects.
So side effects is a big problem. So 1987, we talked about Mevacor coming out. About 10 years later, 1997, Baycol, Bayer Pharmaceuticals, well-known, well-respected company, jumped into the statin market with a big drug, and this was right when I was beginning my private practice. Heavily marketed, had great studies, but after it was out in use, had some serious issues and wound up being pulled from use in 2001. Got a lot of bad press, and that, I think, is where a lot of our fear of statins comes from. 25 years later, hearing about how bad statins were with issues. And I'll go through a few of them. The most common issues with statins are muscle aches, some feelings of fatigue. They can raise the enzymes of our liver because it's processed through the liver. And those do happen about 5 to 10% of the time. They only really become serious issues with muscle breakdown or muscle damage less than 1%, probably less than 0.5% based on the most recent studies. And there are things we can do to work around that. Statins do sort of deplete us of coenzyme Q. We hear that, ads on TV, you get your coenzyme Q if you're on a statin. So that's an enzyme that helps, a coenzyme that helps limit the issues or the side effects of the statin. So if somebody has an issue with problems with the statin, you can either change the statin, and I've done that and people have good success, just like changing from one blood pressure medicine to another. Or you can add coenzyme Q to sort of replace that coenzyme that gets depleted and causes the side effects. A couple other things, there's been some serious pancreatitis, again, back in the earlier statin days that we don't really see anymore. I've had a few people have hair loss, and certainly that can be disturbing. in patients to suddenly start losing their hair. And is it the statin or is it the disease itself? Sometimes it's hard to tell.
Right.
But we work around that, and we really do our best. There are a couple of new medications, if you don't mind me just kind of finishing the drug part of. I'm gonna look on my paper to make sure I say it right. PCSK9 inhibitors. That's a protein that the liver makes to help regulate itself, and it actually takes out the receptors for LDL, the proteins that the liver uses to take up the bad cholesterol. This PCSK9 gets rid of those, so it lowers your amount, so it lowers your ability to get rid of cholesterol. So there are a couple of injectables that block that, so then your liver does have the receptors, so it then can take up the bad cholesterol.
So that's another alternative.
It is. It is. And if somebody really truly can't take a statin, that is an alternative. And sometimes if people have, for instance, genetic hypercholesterolemia or familial hypercholesterolemia, and these are people where their LDL, bad cholesterol, is in the 200 to 300 range. You know, we want the total to be under 200, and some people are bad is that high, and their totals are 400 and 500. They go on both, the statin and the injectable.
So what I'm taking away is this is the importance of establishing that primary care relationship, because you, as my physician, would know my family history, my risk factors, and the best course of action if we're going to do medical intervention for cholesterol problems that could lead to heart attack or a stroke. So that's important to know. And you've done plenty of research on the good and the bad and the best.
It's been a project of mine for the past couple of years to really increase the use of statins. Two things I've found, I looked it up recently just to reaffirm what I saw a year ago. The number of people who could or should be on a statin versus those who are, it's only about 35% in the U.S. And a big part of that, I really want to put this issue out there, is our diabetics. So anybody with diabetes over the age of 40 should be on a statin. Issue I see a lot is the patients say, well, my cholesterol's good, and the doctors, it's partly the clinician's fault as well, say, well, your cholesterol's not bad, just work on it. Why add another medicine? My counter to that is we put diabetics on a type of blood pressure medicine called an ACE inhibitor that helps protect their kidneys from the effects of the diabetes, whether or not their blood pressure is high or not. So if you have normal blood pressure and you have diabetes, we want to put you on this medicine to protect your kidneys. So if you have normal cholesterol, we want to put you on a statin to help protect your heart and your brain from the cholesterol buildup. Because we know, independent of whatever your cholesterol number, high, normal, low, as a diabetic, there's up to a 30% reduction in heart attack and stroke by being on a statin. So even with your normal. And that's, I think, a big message that I want to get out there, that I've been trying to get out to my patients.
Yes.
I see so often, oh, my cardiologist said it was okay, or, you know, my mother had trouble with statins and my cholesterol's normal, so I don't really want to be on it. It's all about that long-term relationship and having those discussions with the patient and explaining them these things that we're talking about today.
Yeah. Well, thank you so much, Dr. Laurent, for coming in and sharing your knowledge, which is extensive, and it's really good in-depth discussion. I appreciate you being here today. So, and thank you for watching. We will be right back with our next guest.
It's never, if you build it, they will come. It's always, if the community needs it, we will build it. The new St. Tammany Health System Surgery Center doubles the number of operating rooms available, lessening wait times, speeding up recovery times. It's the most advanced center of its kind in the Gulf South. An investment in you.
Welcome back to Healthy Living. As promised, I have another guest that's joining me today to talk about heart health and his name is Dr. Rick Casey. He's a pulmonologist, and he's the director of the St. Tammany Health System Sleep Disorders Center. So welcome, Dr. Casey.
Thank you. Thank you for asking me here.
Absolutely. So it's nice to meet you. We've never met before today, but I've heard great things about you and the Sleep Center.
Thank you. I'm so proud of our Sleep Center.
Yeah, I want to talk about the Sleep Center in particular as we get into our conversation, but I do want people to learn a little bit more about you.
Okay. I have been on staff at St. Tammany Parish Hospital for 29 years now. January will make 30 years. We have a group, pulmonary critical care physicians, and in 2020 our group joined St. Tammany as physicians. Then this past December I took over as director of our Sleep Disorders Center.
Okay. Yeah, well, thank you for sharing that about yourself. We talked with Dr. Laurent about heart health, and you are a pulmonologist. You guys pinpoint problems within the body that lead to the sleep disorders.
Correct.
Is that fair to say?
Correct.
So how does sleep quality impact your cardiovascular health, especially in men and women? I think when we're younger, we don't think about that.
Right.
But as you get older, you do notice the impact of sleep or lack of sleep.
And I'm experiencing that too, yes.
As am I, that we just discussed.
No, as you get older, you don't sleep as well, but even when you're younger, sleep deprivation is not good. Be it job, stress, family, things like that. A lack of sleep has been associated directly with heart disease, high blood pressure, even diabetes as well too.
And what's the connection there? Why?
A lot of it is a sympathetic tone, in that, or adrenaline, so to speak, that if you don't get a good night's sleep, you have more adrenaline the next day. Your blood pressure tends to get higher, and there's hormonal factors as well too, but those go hand in hand with those disorders.
Okay, all right. So what are some of the most common sleep disorders that will contribute particularly to heart disease?
Far and away, it's obstructive sleep apnea. Most people heard of sleep apnea. The majority of patients, probably 95%, have obstructive sleep apnea, which is where your throat closes down, your pharynx closes down when you're sleeping.
Okay.
There's another subset called central sleep apnea where your brain just doesn't tell you to breathe. That's different. That's much less common. Insomnia is a problem, just sleep deprivation. There's a rare disorder called narcolepsy, but that's usually in younger people. But far and away, it's obstructive sleep apnea.
So obstructive sleep apnea, how would you even know you have that?
Most people do not know their throat's closing down. Their main complaint is fatigue, or we say non-restorative sleep. When you wake up, you're just as tired as when you go to bed. Quite often they'll be told that they snore or that they stop breathing at night. What I commonly ask patients when they come in is, do you have a good night's sleep? Is that typical? And right away most of them say no. And the problem with sleep apnea is they're sleep deprived, and that goes hand in hand, because if your throat's closing down at night, you can't stay asleep because you're struggling to breathe. So most people with sleep apnea have no problem going to sleep because they're sleep deprived. They just can't stay asleep, and they just don't feel good in the morning. And then they're tired in the afternoon. They have just don't feel good.
So it becomes a cycle.
It is a vicious cycle.
Vicious cycle. And when we talk about sleep apnea, it is particularly common in men. It is, it happens in women too. We talked a little bit about how it contributes to high blood pressure with the adrenaline and atrial fibrillation. Is that the same cause, basically?
Yes. Cardiovascular disease has been associated with obstructive sleep apnea. Particularly moderate to severe. Mild sleep apnea really hasn't been associated, and so people with mild sleep apnea we really only treat if they're symptomatic or they have other health problems. But moderate to severe sleep apnea has been associated with coronary artery disease, atrial fibrillation, stroke, high blood pressure, diabetes. There's a lot of health consequences of that.
Yeah. So when someone does come to you with the symptoms you described, like they went to bed, but they woke up as tired as they were before they went to bed, and then they can get right to sleep, but they don't feel like they get a good night's sleep, or their spouse tells them, oh, you're snoring, it sounds like you stopped breathing. Right. What are the next steps? Once they come to you with that, how do you diagnose it, and then what happens after that?
So the way we diagnose sleep apnea has changed over year because of insurance companies. Historically, we would bring the patient into a sleep lab, which is really the gold standard of diagnosing sleep apnea. We have sleep technicians at night that will put all the monitoring devices on. There's EEG electrodes, so they're kind of fastened to your head at night, and monitors look at your breathing, your heart rate, your legs if they're kicking, and your oxygen level. and then that's the gold standard. Insurance companies have pushed away to that to home sleep studies, which patients really like as well too. So those are devices that you actually come to our sleep lab, and the lab will show you how to put it on. So you go home and you put these devices on at night, you sleep with it in your own bed, and then you wake up, you bring it in, and then the information gets analyzed after that. So patients really like that. It's not as complete and thorough as an in-lab study, but when we're looking at sleep apnea, it takes care of the majority of cases.
So then you have the diagnosis, you have the evidence and the data. Then what's next? In general.
Generally, I ask them what's the likelihood you're going to wear CPAP, because there are plenty of people who say there's no way I'm going to wear something like that. So I really do ask them that. The other question is, do you have a lot of nasal congestion, or are you claustrophobic? Because we have different masks that are used. Most people do well with just a small over-the-nose or under-nose mask. Is better for claustrophobia as well too. But if you're really stopped up in your nasal passage, or then you really need a full face mask. It covers the nose and mouth. But that is the next step. Is CPAP is the treatment of choice for the majority of people.
So do you have any advice for people just in general before sleep apnea becomes an issue? Do you have any advice for people on just how to get a good night's sleep? How do you do that?
We call that sleep hygiene. So there's a lot of things you can ask about. One is the sleep environment. Is the bedroom quiet? Don't have the TV on. Some people say they have to sleep with the TV on. That is really not good sleep hygiene. Do you drink a lot of caffeinated beverages? Alcohol at night doesn't help. Exercise even at night is not really conducive to sleep. So various things about sleep hygiene is very basic questions.
Yeah. Do those sleep masks help?
They can.
Depends on the person, I guess.
Depends on the person. Yeah.
So when we talk about men who are reluctant to seek help for their snoring or fatigue, and women too, what would you say to those patients?
Listen to your spouse or girlfriend or whoever it is, because they're the ones who really know what your sleeping is like. But that is a challenge, because we have people who say, I don't care, I'm not a problem, I don't sleep well. That's not that unusual. Have a patient come in with his wife or girlfriend or whatever, and she'll say he snores, he gasps, and he says, I sleep fine. So that's the challenge.
Yeah.
Because if they have high blood pressure, heart disease, another comorbidity like that, then it's easier to say you really need to be tested. If they don't have health problems, let's say they're 30 years old and they just have the spouse that says they snore, it's going to be a tough sell.
Yeah. And so the benefits, though, if you can back in and get that good sleep going, you can absolutely reduce some of those risk factors for other comorbidities.
Yes. High blood pressure has been the best studied as far as moderate to severe sleep apnea has been associated with high blood pressure, and treatment of sleep apnea has been associated with a mild reduction in high blood pressure. It doesn't get rid of the disease or get rid of the need for blood pressure medicine, but it does help control as well too.
Okay, so tell people, I am not familiar with what our sleep lab even looks like, to be honest. So can you tell people what to expect when they would come there?
If you're coming in for an in-lab study, it's different from if you're getting a home sleep study. Home sleep study, you just come into lab, they'll show you how to put on the equipment, then you go home. An in-lab study, there's a technician at night who's very skilled. We have very dedicated workers at night too. You'll be hooked up to monitors that monitor your stages of sleep. It's EEG, kind of like a seizure type protocol, but it's not. So you have little electrodes glued in your hair. You'll have a little nasal thermistor here, little devices near your nose and mouth to check for airflow. You'll have a belt on your chest and abdomen to check for respiratory movement, an oxygen sensor, and also a heart rate monitor. And then, believe it or not, you will go into a bed and you will fall asleep. Most people don't think they can sleep with that many hookups, but most people going to lab do have sleep apnea, because we kind of test the people ahead of time. In other words, with history and physical.
Sure.
Like, are they likely to have sleep apnea? So the majority of the people who get a sleep study do have sleep apnea. So actually most people do sleep in the sleep lab.
Okay, and so you evaluate them like that. Okay, that's good to know. And it's good that we have that capability right here in our own health system. Yeah. So I know we talked with Dr. Laurent. He's an internal medicine doctor. Primary care relationship very important to issue spot things like this.
Oh, yeah. The vast majority of referrals to the sleep lab are from our primary care network, by far. Yeah. So that's good. They've been picked up on sleep apnea, the comorbidities. Cardiologists send people for sleep studies. They have plenty of people with heart failure, which is definitely an issue when you have obstructive sleep apnea of heart failure. So they're good at picking that, screening patients for that, too.
Yeah. Well, is there anything else you would like to add around this discussion, particularly about what you do and your team and how you can help our community?
Our team is growing. You know, we're North Lake Pulmonary Associates. We actually have 2 nurse practitioners that sleep apnea patients as well. I think the sleep lab is great. This year we just got reaccredited with American Academy of Sleep Medicine, which is the highest standard for sleep lab. So we're thrilled to death with that. That's a 5-year accreditation. So
Yeah, a lot of work for that.
yeah,
Congratulations.
Yeah, very happy with them.
Well, I appreciate you coming in here and sharing your expertise with us, and we will likely ask you to do it again in the future.
Not a problem.
So thank you so much, Dr. Casey. And thank you for joining us for Healthy Living. We'll see you next time.